Okay, dressing selection and bandaging, chapter 7. You probably noticed, if you've looked at this, there's 126 slides in this presentation. I'm going to go through some of them fairly rapidly because once you get the idea about what is the dressing that you need to select, given the features of your wound or the characteristics of the wound that you're trying to select the dressing for, it becomes very, very obvious. So I will have a selection of these dressings and bandages when I am on campus next week, so that you will get to see them and be hands-on with them. The other thing I want to tell you is that you will be getting back at least 2 of your quizzes tonight. And then finally, I had an email, and I will post this as a announcement or an email to all of you, but I had a question regarding the midterm, and I know there's some concern about the midterm and what it's going to look like. When I'm on campus, by the end of this week, I will post a study guide for you. When I'm on campus, I will also have some examples of questions for you, so you'll know what the structure of the questions looks like. Okay, all right, moving on. Chapter 7, dressing selection and bandaging. All right, here's 2 videos. One is a dressing change with irrigation, and one is a dressing change with Montgomery straps. We'll see later in this presentation what Montgomery straps are. I will pull these videos. I do also understand from Dr. Caston that you can't see the videos from the presentations, so I will pull the videos for Chapter 6 and Chapter 7 and get them on Moodle, post them to the week. That may not happen until the weekend, but I will get it done. All right, so the main thing, if you learn nothing else in this course, the main thing I want you to know is that wound healing occurs in the presence of moisture. There must be moisture for a wound to heal. Moisture facilitates all 3 phases of wound healing. Hopefully by now you guys can tell me what the 3 phases of wound healing are. So it traps endogenous enzymes to facilitate autolytic debridement. Remember we talked about the serous or serous sanguinis fluid that you would see coming from the wound. This has the white blood cells, all of the enzymes that fight necrotic tissue, fight bacteria, everything that the body does to facilitate the healing process. It also preserves endogenous growth factors. Again, yesterday we talked a little bit about topicals and antimicrobials and that kind of thing. And so what we're trying to avoid in killing these endogenous enzymes, these endogenous growth factors, because it really impedes the healing of the wound itself. Moist wound healing reduces patient pain complaints. As long as the wound is moist, then there's not going to be as much pain. And it results in a more cosmetically appealing scar. I think we see the picture again. I know we've seen it a number of times that compares, there's an elbow with a few little wounds on it, and it compares a dry healing wound to a moist healing wound, if you remember that picture. All right, so if a wound is too moist, you get maceration. You know, the white tissue that we see around a lot of the neuropathic wounds that we see, a lot of the wounds we see on the feet, there's white macerated dead tissue. It's too wet, it's drowned, and that causes additional skin damage, and it causes the ulceration, the wound to get bigger, and it also increases the chance of infection. As we talked about yesterday, the bacteria loves that medium to grow on. It grows, and you can get an increased risk of infection once you have that critical colonization, and then it goes into the deeper tissues. You have that infection. If it's too dry, you get the crust formation, and you don't have the enzymes, the endogenous enzymes, which are tearing down the necrotic tissue, but you also don't have the endogenous growth factors because the tissue is just too dry for those to exist. So at the bottom it says a moist wound environment is like al dente pasta. It's just right. All right, so what is the functions of a wound dressing? The functions are to create a moist environment. Again, wound healing happens in the presence of moisture. It's to provide thermal insulation. You remember early on we talked about the temperature is a factor in wound healing. There has to be a certain temperature for the wound to heal. If it's too cold, it won't heal. So a wound dressing provides some of that thermal insulation. It provides a homeostasis on the wound bed. So it gives it some consistency so that the wound can heal. It controls edema, and it can eliminate dead space within the wound bed. So this is really important. We've talked maybe a little bit on this. I've touched just a little bit on this, but I want to touch even more on it now. So if there is dead space within the wound bed, meaning that the wound bed's very deep and there's a lot of space between the bed and the top of the wound, a dressing can eliminate that dead space and encourage the body to heal. The body will not heal over a dead space. So by putting the dressing in the wound, it eliminates that dead space and encourages the body to begin to fill. It encourages granulation tissue. It encourages, once the granulation tissue fills, that it encourages epithelialization across the top of that granulation tissue. All right, here is an example of what we just talked about. So there's an abscess formation due to dead space. You see in B, you see the intact skin over the abscess. And then you see in C, you see their colonizing bacteria is going to multiply and cause an abscess and potentially increase the size of the wound. So this is a perfect example of what happens when there is dead space in a wound. All right. Some more functions of the wound dressing. A primary dressing is any dressing that has direct contact with the wound. An example of that is a Band-Aid. Any dressing, usually a 4x4 or a gauze pad or a Telfa pad, which is a kind of gauze that's coated so it won't stick to the wound. All of those are considered primary dressings. A secondary dressing is something that goes over the primary dressing. It can provide protection, cushioning, absorption, occlusion. It can provide a number of things. So if, for example, my primary dressing is a 4x4 gauze pad, then my secondary dressing can be gauze that's wrapped over the top of it. Or it can be a type of foam if I've got a lot of drainage and I know that that gauze is going to be overrun by drainage. It can be a foam dressing that goes over the top of that. That can be a secondary dressing. Moisture retentive dressings, let's talk about some specific types of dressing. So a moisture retentive dressing can be synthetic or organic, and it maintains a moist wound environment. And so if it maintains that moist wound environment by occlusion, the dressing itself transmits water vapor and bacteria. It occludes that wound environment. It traps the wound fluid, and it has a really low moisture vapor transmission rate, meaning that, remember we talked about when the top layer of skin is gone, there's a huge loss of moisture. Well, a moisture retentive dressing prevents that moisture from evaporating. It prevents that from being transmitted outside the wound and decreasing the moisture content of the wound bed. That's one of the primary roles of the moisture retentive dressing. It can also facilitate autolytic debridement. We talked earlier about this when we talked about autolytic debridement. So if I have a wound and I simply wrap saran wrap or a plastic wrap around the arm where that wound is, it's going to retain moisture. Moisture is not going to make it through the barrier of that plastic wrap. So whatever endogenous enzymes I have in there that are decreasing bacteria and necrotic tissue, it's going to facilitate them because it's going to hold them right there on top of that wound bed. It can also decrease pain, and it can increase your rate of healing. So depending on the moisture retentive dressing you have, part of the sales pitch that they'll give you is they have various absorption rates. A moisture retentive dressing can also lower your infection rates because you're covering that wound bed. Again, those endogenous enzymes are there so that you're not allowing that bacteria to colonize at the rate that it would if it was open. It can also, a moisture retentive dressing can also give you a non-traumatic removal of necrotic tissue from the wound bed, meaning that we've talked about a 4x4 or wet to dry, if I wet it and put it in the wound bed and then I remove it, it's a traumatic removal because it's dried and there have been cells that have attached to that, and I'm going to rip it out of there and those cells are going to come out with it. A moisture retentive dressing, because it's never going to dry, those cells aren't going to adhere to the dressing itself. But the necrotic tissue can be devitalized and can be taken care of by the endogenous enzymes. So when you remove the dressing, you can also remove necrotic tissue. It can be water resistant, so that's for patients that need to bathe or wash dishes or swim, those kind of things, anything where you have you have a water resistant need. And then moisture retentive dressings can be both adhesive and non-adhesive. Moisture retentive dressings are conformable to the wound. So if you have a weirdly shaped wound or a large wound, these can conform to the size of the wound because they come in various shapes and sizes. They require less time for a dressing change. They require fewer dressing changes. You remember when we talk about autolytic debridement, we talked about there being fewer dressing changes because you want to give the wound time, those endogenous enzymes time to work and to get rid of that necrotic tissue. So moisture retentive dressings require fewer dressing changes. They are costlier than gauze, a normal gauze pad. There is more cost to them. And generally you need 1 to 2 centimeters of border of intact skin. So if you've got a really large wound and there's no intact skin around it, 1 to 2 centimeters, then you may not be able to use a moisture retentive dressing because there's going to have to be the border which will actually adhere to that intact skin. And if you don't have that, if there's just a very wet wound or a moist wound, that border is not going to stick to it. All right, here's that picture that I talked about that we've seen so many times. This is an example of a moist wound healing versus a wound that's open to air. Again, on the left side, it's my left, I hope it's your left, you see the moist wound healing. On the right side, you see where it was open to air and it's a little more scabby looking. All right, here's the most common fears when you talk about using a moisture retentive dressing. Number one is, it's going to cause infection because a moist environment facilitates colonization. In fact, occlusive dressings have lower infection rates compared to non-occlusive dressings. So if we think about it, the reason is they are actually creating a barrier to the bacteria that could be colonizing on that wound. If you have an occlusive dressing, it's occluding any bacteria from settling on that wound bed. And as we've already talked about, any bacteria that's already on that wound bed, there's going to be the endogenous enzymes that are going to kill that bacteria. So an occlusive dressing serves as a bacterial barrier. It's impermeable to urine and stool. So if there's any kind of wounds in the perianal region, you put an occlusive dressing on them and you can keep urine and stool out of the wounds, which is a very good thing to decrease infection. It facilitates neutralization of the microorganisms. As I just said, those endogenous enzymes are going to kill that bacteria or help to kill because you are occluding anything else from getting in there. You're also doing removal of necrotic tissue and debris. Again, autolytic debridement, because you're occluding it, all of those enzymes are breaking down that necrotic tissue. Once the key to using a moisture retentive dressing and controlling infection is if the barrier becomes compromised, you have to change the dressing. So especially in the perianal region, remember I talked about there has to be that border so that the adhesive border can really stick and really create that occlusive dressing. But if that becomes compromised or it opens up, you have to change that dressing immediately. Immunocompromised patients may require more frequent dressings because you want to make sure that that occlusion is always there and that it's not opening up and giving a chance for bacteria to flood in there and then occluding that bacteria in there. Most types of moisture retentive dressings, as soon as you see infection, they are discontinued. There is some exceptions with alginates and foams, and as we go through this, we're going to talk a little bit about alginates and foams and what they are and how they work. And you'll see why they don't really need to be discontinued if infection is present. All right, so small thing, but very important, is that when you're putting a wound dressing on, you always want to make sure that this wound dressing is tightly adhered to the wound. Make sure there's no wrinkles, there's no creases, much like I talked about, when I talked about a blister. So if the blister pops, I said you always want to debride that skin off of the top of that blister. It's the same way with a crease or a wrinkle in a dressing. If you allow there to be a crease or a wrinkle, then there can be a pathway for bacteria to get in there. It's no longer occlusive. Those microbes can enter into that, where that crease or that wrinkle is. Just like I said, if you leave that skin on after the blister has popped, then that skin can provide a tent, if you will, for microbes. All right, another common fear is that it will, about having to do with the wound bed and the surrounding skin, moisture retentive dressing will traumatize the intact skin because of the adhesive. The adhesive on these are less tacky than a regular silk tape that you see, in hospitals all the time. The removal doesn't pose a threat to healthy skin. You can use skin sealants and barriers to the intact skin prior to putting it on if you think that there's going to be a maceration or a skin trauma. And the other thing is that breakdown can occur if it's changed too often. So if you're constantly ripping, remember we talked about a moisture retentive dressing is not changed as often. So it's not like you're ripping this adhesive on off the skin like 2 to 3 times a day. You really aren't. But if someone does have a reaction to an adhesive, or if there is a changing of the dressings multiple times a day, then yes, there's probably going to be, the surrounding skin's probably going to be traumatized. But if the moisture retentive dressing is used correctly, there should not be trauma to the intact skin. All right, so here's a nice little table or figure that shows us, it gives you an idea of dressings and which ones are more occlusive and which ones are more permeable. So on your vertical axis, you see occlusiveness. How much are they going to limit anything from getting into the wound bed? And on the horizontal axis, you see the permeability. How much is stuff going to get in or get out? So we run from the very left-hand corner, non-occlusive and totally permeable, which is leaving it open to air. Obviously, that's as unocclusive and as permeable, or non-occlusive and as permeable as you can get. And then it goes to loose weave gauze, fine weave gauze, calcium alginates, and it goes up the chain. So what you can see here is the most occlusive and the most impermeable dressing would be latex. So if you put latex over someone, it is very occlusive and there's nothing that's going to get through that dressing. Okay. So that's how this little table will help you when you start thinking about what dressings, if you need an occlusive dressings, what are your more occlusive dressings and what are your more permeable dressings. All right, here's another one that is talks about absorption. So let's say you have a very wet wound. There's a lot of enzymes. There's a lot of fluids coming from this wound. So the most absorptive and the least absorptive are on this this figure here. So this has both composite and antimicrobial dressings. So composite means that there's two different types of dressings, and we're going to talk about that, and I'll show you what a composite dressing looks like when I'm there. But a composite means that there's just two different types, because it could be, for example, a gauze with a hydrogel in the middle of it, or it could be a hydrocolloid with a foam in the middle of it, or an alginate in the middle of it. So that's what a composite dressing means. And so this gives you an idea of absorptive, how absorptive the different dressings are. So again, the most absorptive you see on the top of the moisture retentive dressings is an alginate. And then the most absorptive of the gauze dressings is just layers of gauze padding. You just layer upon layer. It's going to be more absorptive than just a single woven gauze. All right, let's talk a little bit about gauze dressings. It's a cotton woven gauze, and there's also the non-gauze, which is a synthetic, and it's more absorbent. These are highly permeable. They're relatively non-occlusive, meaning that there's a lot that goes in and out. They're not going to occlude. There's a finer weave, small pores, decreases the wound bed trauma. So if it's a really large weave, you're going to see more trauma once you pull that gauze dressing off of that wound bed. It can be a primary or a secondary dressing, and the biggest reason that you'll see this used a lot is that it's inexpensive for if you're using it just one time or a short-term use. Here are some examples of some gauze products. The one on the top is a non-adherent gauze. What makes it non-adherent is that it's impregnated with a petroleum, a Vaseline type substance, petroleum jelly. That's what makes it non-adherent. B is just a plain gauze square. C is an absorbent gauze pad. D is a gauze roll, which is generally used as a secondary dressing on top of another type. G is also a gauze roll. So again, depending on if you need D, which is a larger version, or G, the smaller version. E is a bismuth impregnated gauze. So what that is a gauze that's impregnated with betadine type of solution. So it's antimicrobial. And then the F is also a petroleum impregnated gauze that, like I talked about in A. So, precautions and contraindications. Woven gauze, as I've talked about before, may require more force for removal. It may leave residue, so there's actually fibers that can come off of the gauze and stay within the wound bed itself, so you get this residue or lint on top of the wound bed, which of course can at times cause a problem or inflammatory process because the body sees it as something foreign in the wound bed. If the wound gauze does get if the woven gauze does get dry, it will adhere to the wound bed. Rolled gauze should be applied at an angle without tension, because you don't want to cut off circulation using a rolled gauze. And Telfa dressings are used for superficial non-draining wounds. Telfa is the one I mentioned earlier, and it's a non-adherent type of dressing, but it will not absorb anything. So if you've got a heavily draining wound, you can't use a Telfa dressing. But if you've got a nice moist wound bed that's not really draining a whole lot, you can put a Telfa dressing on there, and it won't pull off any of the immature cells on that wound bed. So let's say you slide down the sidewalk and give yourself a nice raspberry on your knee. A Telfa dressing is really nice to use on that type of superficial wound like that. So, common uses for gauze dressings are for infected and non-infected wounds. Basically, wounds of all shapes, sizes, depths, or etiologies. Wounds requiring packing, frequent dressing changes, highly exudating wounds. If you've got a lot of drainage coming out of a wound, you're probably going to use a lot of, you're going to probably pack it with gauze. And then patients with a fragile skin integument. So you use a roll gauze, like I said. You may use a roll gauze as a secondary dressing, so you'll roll it around the primary dressing and then tape the gauze itself, not to the skin but to itself, so that you have that secondary dressing and you protect the primary dressing and you also protect the skin of that person. The benefits are that you can get it anywhere. If you use it one time, it's a low cost. You can use it on infected and uninfected wounds. It can be used alone or with other dressings or topical agents. If you need to get more absorption, you just add more layers. It provides a cushioning to the wound bed, and it keeps adhesive off of patient's skin. Basically, gauze is the basic level, if you will, of wound dressings. Limitations is that if it's used consistently over time, it does get costly. Like anything, long-term use of anything is going to make it costly. The biggest limitation, though, is it may adhere to the wound bed and it may leave particulate matter in the wound bed. Remember I said some of the fibers can come off and actually become a part of the wound bed. It is highly permeable. Anything's going to get through it. So especially if you're using gauze in the perianal area, it's not going to control urine or stool or anything from getting in the wound. It requires more frequent dressing changes because, again, highly permeable. Everything's going to get into it. And you will have a higher infection rate with a gauze dressing than you would with an occlusive dressing. Again, everything's going to get into it. All right, here's some names and prices. I'm not going to read through these as we go through them, but just to give you an idea, you'll hear people talk about Curlex or Cling or that kind of thing, and it's just a type of gauze dressing. It's a roll of gauze dressing. Here's packing strips. When I said earlier that with gauze you can pack a wound, remember we talked about the dead spaces. It's important that we get rid of the dead spaces so the body heals, because if you leave the dead spaces there, the body will not heal. It senses that dead space. So here's an example of a packing strip, and the packing strip is what you put into that dead space within the wound to encourage it to heal. All right, let's talk about impregnated gauze dressings. So the gauze dressings can be impregnated with petroleum or Vaseline, bismuth, or kind of a betadine kind of thing, zinc, hydrogel, or saline. The main reason for this is it makes it a non-adherent contact layer. So you've got a gauze, but it's not going to adhere to that wound bed. And it does require secondary dressing, and it does increase the occlusiveness of the gauze dressing. Because you've impregnated any of these things that are listed in that gauze dressing, it makes it more occlusive than if you use just a regular gauze. All right. This is the same. Yeah, this is the same slide that we saw earlier. So I'm just going to keep going on this one. So dressings with bismuth, which is also the yellowish stuff that you saw, you see these a lot used in burns. They are cytotoxic to inflammatory cells. Remember I told you earlier yesterday when we were talking about betadine that it is cytotoxic, and so these dressings are cytotoxic to inflammatory cells. It will, if you put it on a patient with a venous insufficiency ulcer, you're going to get you're probably most likely going to get an inflammatory response in those patients. Anything that's impregnated with iodine is also cytotoxic, and it's only mildly antimicrobial. So the benefit of using either one of these is not great. Really, there's no reason to use these dressings. If the physician orders it, oftentimes I would call the physician and request that we be allowed to change to something else. If the physician did not agree with that, then I would try to document patient's reaction to it so that I could then call them back and let them know about the wound reaction so that we could get the patient towards a more appropriate dressing. So, I said earlier, common uses are burns, granulating wounds, epithelializing wounds, wounds where you have exposed tendons. You guys remember really early on I talked about tendons are really hard to keep moist. So you would use some kind of impregnated gauze over an exposed tendon. Wounds that bleed easily. Why? Because you don't want to use a dry gauze dressing over something that bleeds easily, because as soon as you rip it off, you're going to cause it to bleed again. So you use something that's impregnated so that it'd be non-adherent to the wound bed. And then painful wounds. Something that's not adherent is going to be it's going to be less painful on a wound bed. The benefits as a decreased wound bed trauma with dressing changes, you can decrease the pain and it may increase the occlusiveness of the gauze dressing. Limitations is it's more costly. It does require secondary dressing. You have to put something around it. You can't just put it on the wound and let the patient go. There's got to be another dressing around it. And it may present a barrier to keratinocyte migration. Now, if you guys remember, I won't tell you, but if you guys remember what keratinocyte migration is, what phase is that in, and what does that keratinocytes, once they start migrating, what are you going to see happening to the wound? That's a really good question for you to ask yourself and make sure you have that level of knowledge. And an impregnated gauze dressing has minimal absorptive capabilities. So if you've got any kinds of exudate, a lot of fluid coming out of that wound, this is not the dressing you want to use because it's just not going to absorb anything. Now we're going to talk about semi-permeable film dressings. So it's a thin sheet of transparent polyurethane with an adhesive backing. It looks like it just looks like a layer of a saran wrap or a plastic sheeting. It is permeable though to water vapor, oxygen, and carbon dioxide. It's impermeable to bacteria and water itself. It's not absorptive, but it does have insulating capabilities, and it allows visualization of the wound bed. It's highly elastic and conformable, so if you have a weird shaped wound, then this semi-permeable film dressing is a good one to use. These are some examples of moisture retentive dressings. The one I just talked about is A. So if you see the finger between that, that's a semi-permeable film dressing. Okay, again, it just looks like a sheet of plastic wrap, but it's not a plastic wrap. It is semi-permeable. So B is a sheet of hydrogel. C is a sheet of alginate, calcium alginate. The calcium alginate is made from, it's a derivative of seaweed. And as you see there, it looks kind of like a cotton, and I'll show you when we're in the integumentary lab. But when you wet it, it gels. It creates a gel. So if you put a sheet of alginate in a wound bed, you always want to make sure there's some kind of moisture in that wound bed, meaning that you would not ever want to use alginate in a dry wound. You should only use alginate in a moist or wet wound, because what it will do is it will absorb all those endogenous enzymes, all those endogenous fluids, and hold them right next to the wound, which makes it such a nice dressing, because remember what's in those fluids. You've got the growth factor, you've got the enzyme, you've got everything that helps that wound to heal. And so when this calcium alginate turns into a gel, you're holding all of that nice healing fluid right next to the wound bed. So it really encourages wound healing. D is an alginate tipped applicator, so that has alginate on the very tip of that applicator. E is a hydrocolloid. This is used quite a bit around in the perianal region, because it is occlusive. and it will help keep out, as was said earlier, urine and stool. And then F is a semi-permeable foam. So again, it will absorb moisture, but it doesn't let everything in. It doesn't let bacteria and that kind of stuff in. So those are all examples of moisture retentive dressings. As we talked about earlier, you always want to make sure there's no, you're not making wrinkles or creases, but also that you're not stretching them across the skin, because you don't want to stretch the skin. You don't want to cause a tension underneath that dressing. The semi-permeables can be left in place for 5 to 7 days. Once you see a channel, meaning there's enough fluid buildup underneath the semi-permeable film that it starts to develop a channel with underneath it, then you need to change it. You'll see semi-permeable film dressings a lot on skin tears. So if you're in a long-term care facility and you see someone with a skin tear, generally they have a semi-permeable film dressing over the top of it. So precautions and contraindications for these are, you may have to use a skin sealant to protect the peri wound. Again, because you think about it, what are we sealing in? We're sealing in all the fluids. So the peri wound can become macerated. So you may need to use a skin sealant on it before you put the semi-permeable film on. You have to have a good edge seal. So in other words, it has to adhere to the skin surrounding the peri-wound skin. It has to adhere to it really well to seal out or to seal in all of the moisture and to seal out, to be a barrier to bacteria. You should not ever use these on infected wounds or wounds with moderate to heavy drainage. I hope that both of those things are make a lot of sense as to why you would not. Or patients with fragile skin. I did talk about them using it on a skin tear, but if the patient has a really fragile skin, you have to be careful of that. Common uses are superficial or partial thickness wounds, skin tears, donor sites, areas of friction, abrasions, over IV catheters. So if the patient wants to go to bathe or is going into the whirlpool, they'll put these over these semi-permeable film dressings over IV catheters, or over wounds if you're going to use ultrasound. We're going to talk about next week when I'm there. We're going to talk about modalities for wound healing, and ultrasound is one of the modalities that is used in wound healing. And so you would want to put a semi-permeable film over the wound bed for an ultrasound treatment. The benefits is moisture retentive, encourages autolytic debridement, reduces friction. You can actually see through a semi-permeable film, so you can see what the wound bed looks like. It's waterproof, and it costs less over time because, again, remember, you're not changing it as frequently, so it can cost less over time. Limitations is that it can traumatize the peri-wound area upon removal if you're not really careful when you're removing it. You cannot use it on highly exudating wounds, really wet wounds. You cannot use it on. It can be hard to apply because, remember, you don't want any creases or lines in it. And when you first put on a semi-permeable film, it just sticks. It's like it sticks to itself. So it is difficult for people when they're first learning to put on a semi-permeable film dressing to get it right and to get it smooth. You can't use it on infected wounds, and you can't use it if there's wet or oily skin around it. It won't adhere. There's an example of a semi-permeable film being put on a heel. Again, really difficult. You have to practice some to make sure that there's no creases and that it's even. So after the clinician actually applies this on the heel, then you would rub out all creases and all crinkles within the semi-permeable film, so you'd make sure that it was a very smooth environment so that nothing could get in. All right, common examples of semi-permeable film dressings. Here's just some names. Tegaderm, Opsite are the ones that I've seen the most. You may see any of these within your clinical settings. Let's talk a little bit about sheet hydrogels. Sheet hydrogels are 80 to 90% water or glycerin based. It's a gauze that has a sheet is gel or impregnated over the top of it. It will absorb a minimal amount of fluid. The main reason that you would use a sheet hydrogel is that it would give moisture to a dry wound. So when you're looking at using a hydrogel, it is not for a wet wound, it is for a dry wound because it will give a little bit of moisture to the wound itself. It is permeable to gas and to water, meaning O2, oxygen, and CO2, carbon dioxide and oxygen. There's an exchange, so it is permeable to both of those. It may decrease the pain. Again, think about a dry wound. If I put something on top of it that gives it a little bit of moisture, it's going to decrease the pain of that wound bed. And it's almost secondary, it's almost non-adhesive, meaning it won't adhere to, 9 times out of 10, it won't adhere to the wound bed. But you will need a secondary dressing over the top of it. Here's the example of a hydrogel that's impregnated with silver. I talked about, when we talked about antimicrobial, silver is a very common antimicrobial that's used in dressings that makes the dressings more expensive. And there's a lot of evidence coming out within the last 3 to 4 years showing that it really doesn't make long-term use is not of a silver impregnated hydrogel is not evidence-based. Now short-term use is in the short term it will do really good things for decreasing bacterial load, but long-term use is it's expensive and it doesn't show a quicker healing rate. All right, should not be used on heavy draining wounds, again, because it's a hydrogel, and it should not be used on infected wounds. It absorbs fluids very slowly, and you may, because it's contributing moisture to a dry wound, you may need to use a skin sealant on the peri-wound area because there may be too much moisture. It may macerate the peri-wound area if you don't use a skin sealant. Common uses are minimally or moderately exudating wounds, blisters, abrasions, or skin tears, burns, both thermal and radiation burns, donor sites, mastitis, and to decrease the pressure or shear or provide padding and casts. They'll use hydrogels. If you're putting a cast on and it's over a very bony prominence, you can use a sheet hydrogel over the top of that bony prominence. It can also be used to add moisture to the wound bed, to soften an eschar, or to use, you can use them amorphous. This is amorphous hydrogel, by the way. So it means it's not a sheet. It's something that you squeeze on the wound bed. It is also used as a coupling agent for ultrasound. So when you guys do modalities, if you've done modalities, what you squeeze onto the patient's body before you do an ultrasound, that is an amorphous hydrogel. The benefits of the sheet hydrogels is their moisture retentive dressing, they encourage autolytic debridement, and they're minimally or non-adherent. Limitations is they may dehydrate. So in other words, if you put a sheet hydrogel on someone and you expect it to continuously hydrate that wound, it's not going to do that. So you have to be careful in how quickly you change it, because people think of hydrogels as contributing moisture, but it doesn't contribute moisture for hours on time, days on end. You cannot use it on heavily exudating wound, generally requires a secondary dressing, and you should not use these on infected wounds. Here's some common examples and names of hydrogels that you'll see out there. Semi-permeable foam. So there's a couple of types of semi-permeable foams. Polyurethane foam is hydrophilic on the wound side, meaning it will absorb fluids on the wound side. Hydrophilic, hydrophobic on the outside. So it's going to absorb any exudate on the wound side, but it's going to prevent any moisture from getting in on the outside. So it's hydrophobic. And some have a semi-permeable film backing, and that would be an example of a composite dressing, because you'd have a semi-permeable foam on the inside and a film backing on the outside of it. It is permeable to gas, so you can get an exchange of oxygen and carbon dioxide, but it's not permeable to bacteria, and it does provide a thermal insulation. It will provide cushioning. It's easy to apply and remove, and there are both adhesive and non-adhesive forms of semi-permeable foams. So in other words, there's some of them that already have the adhesive strip we just talked about. They may have a semi-permeable film dressing on them. Well, that would be adhesive because it's already got that film on the outside of it. But there's also foams you can get that don't have any kind of adhesive on them. So you would lay it in the wound bed. It would be a primary dressing, and then you'd use a secondary dressing over the top of it. Here's the moisture retentive dressing film slide that we've already seen. Sorry. So I'm not going to go over it again. Precautions and contraindications. You cannot put this over dry or eschar covered wounds. Why? A foam is for a wet wound. If it's a dry wound, you're not going to do anything because it's not going to provide moisture. It is for a wet wound, so it's only going to absorb. It's not going to provide, so you don't want to use it on a dry or eschar covered wound. It is not indicated for arterial ulcers. The reason being that what is the problem with an arterial ulcer? Perfusion. There's not enough fluid. Generally, an arterial ulcer is going to be dry. So we go back up to that top one. It's a contraindication because generally an arterial ulcer is a dry wound. You don't want to put a foam on top of it. It's not ideal for heel ulcers. Simply because of the foam nature, the semi-permeable foam nature of it. With a heel ulcer, their heel ulcers are a little bit different. You want to give them an opportunity to kind of autolytically debride, and a foam won't allow that to happen. A skin sealant may be needed to protect the peri wound. We already talked about that because there may be a lot of moisture. If there's a heavily exudating wound, then that foam is going to get wet, and it's going to be wet on top of that peri wound. So it may macerate it if you don't use a skin sealant. Common uses are minimally to heavily exudating wounds, donor and ostomy sites, minor burns, granulating or slough-covered partial to full thickness wounds, neuropathic ulcers, or venous insufficiency ulcers. The neuropathic, and as you'll see when we get into those, neuropathic and venous insufficiency ulcers are very, very wet wounds. Benefits is moisture retentive, encourages autolytic debridement, provides thermal insulation, provides cushioning. It absorbs a moderate amount of drainage, and it's available with and without an adhesive backing. Limitations is it may traumatize the peri wound. Again, it's soaking up fluids. It's soaking up exudate. So if you don't protect that peri wound skin, it's going to get macerated. In areas of friction, it may roll. So generally, when this is said, it's talking about the perianal area. It may actually roll and cause some more problems. It should not be used on infected wounds unless you're changing it on a daily basis, because it can't hold that infection. It's going to, again, soak up that bacteria and will hold it directly or right next to the wound bed. So it needs to be changed frequently if you're using it on an infected wound. There's an example of a semi-permeable foam. You cannot see, okay, so the part you're seeing obviously is the hydrophobic side. The hydrophilic side is on the other side next to the wound bed. So just think of when you see this, you think, well, it doesn't look like a foam. That's because you're seeing the hydrophobic side. This is a side that's going to not allow water in or fluids in. Here's some examples, some names, and the approximate cost. Hydrocolloids. Hydrocolloids contain hydrophilic colloidal particles. They have a strong film or foam adhesive backing. They absorb fluid very slowly, and they swell into a gel-like mass. Now, I've already talked to you about the alginates, and you're gonna see alginates again in a minute. But hydrocolloids and alginates both, once they absorb the fluid, they get gel-like on the inside. Within the hydrocolloids will absorb a lot of fluid, a wide range of fluid. They're impermeable to water and oxygen and bacteria. Okay, so a lot of times in a long-term care facility, you'll see hydrocolloids used, and the most common one there is to talk about Duoderm. And Duoderm is an effective barrier against urine, stool, MRSA, Hep B, HIV, and Pseudomonas. So it will keep a lot of stuff out of the wound. The hydrocolloid is E. That's the big brown, and you can see where it looks like it's more of a gel type. It looks like it's a thicker one. I have hydrocolloids that you guys will get to see during lab. Precautions and contraindications is you don't want to use it on heavily draining wounds or bleeding wounds. It will take only a certain amount of moisture. So if they're bleeding or heavily draining, you don't want to use a hydrocolloid. You don't want to use it on infected wounds, a dry wound, a wound with minimal drainage, anything with exposed tendons or fascia. Again, we talked about this. Exposed tendons or fascia need moisture. A hydrocolloid will not provide moisture. It will only soak up moisture. You don't want to use it on patients with poor skin integrity, and be very cautious in using it when people with immunocompromised, a patient who's immunocompromised. Common uses are partial to full thickness wounds, granular or necrotic wounds, minor burns, venous insufficiency ulcers. Remember I talked about those are wet wounds, so you would could use a hydrocolloid on a venous insufficiency ulcer. Burns, pressure ulcers, especially sacral and coccygeal pressure ulcers, and on the peri-wound as an attachment for adhesive tape. So what does that mean? Okay, so let's say I'm using another type of dressing in the wound bed, and then I put a hydrocolloid on the peri-wound because it will protect the peri-wound, and I can put adhesive tape on top of the hydrocolloid because it's going to stick to the peri-wound. So the adhesive tape goes on the hydrocolloid and not on the peri-wound skin. Benefits: moisture retentive, autolytic, thermal insulation, waterproof, it absorbs moderate amounts of drainage, it's impermeable to urine, stool, and bacteria, and it provides a moderate absorption. Limitations is it may traumatize the peri-wound because, again, it's absorbing fluids. It may roll in areas of friction, shouldn't use it on infected wounds. Hydrocolloids can leave a residue in the wound bed. Remember I talked earlier about gauze can leave fibers. Well, hydrocolloids can leave some of that colloidal material in the wound bed, and it can cause hypergranulation. So you have to be very careful and watch the wound. If you're using a hypercolloid, if you start to see hypergranulation, then you're going to have to use another type of dressing. There is an example of a hydrocolloid. Here's some of the names and the cost of hydrocolloids. Tegaderm and Duoderm are the ones that you're going to see most frequently. It is available in sheets. It's available in paste and a powder. Alginates. So alginates are the salts of alginic acid from brown seaweed. I told you it's derived from seaweed. It reacts with the serum and wound exudate to form a hydrophilic gel to provide a moist wound environment. Hydrophilic means it loves water. It loves fluid. It's highly impermeable and non-occlusive. It does require a secondary dressing, but this is the best part of it. It can absorb 20 times its weight. So 20 times its weight. If you have a heavily draining wound, alginate will do a beautiful job of taking all that exudate and keeping the peri-wound area from being macerated. The alginate is the sheet that you see in C. Again, it looks like it kind of looks like a cottony. If it's dry, it looks like cotton, and then once it gets wet, it turns into a gel. All right, used on full thickness or third-degree burns, you don't want to use the alginate on that because generally those are dry, and an alginate, again, is going to absorb moisture. You don't want to use it on dry or minimally draining wounds. You don't want to use it on wounds exposed with tendon, joint capsule, bone, fascia. I'm hoping you guys are beginning to see a trend here, so that if it's a dressing that absorbs fluids, you're not going to use it on anything that needs fluids. Okay, that's the precautions and contraindications. The common uses are highly exudating wounds, venous insufficiency ulcers, which again are highly exudating, tunneling wounds, and then they use it on swabs so that you can probe and measure wound depth a lot, because it will absorb whatever fluid it might be at the bottom of that depth. Benefits is it encourages autolytic debridement. It's highly absorptive. You can use it in infected and uninfected wounds. It is biocompatible in that it will absorb those endogenous enzymes and allow them to sit right next to the wound bed. So the growth factors and the enzymes promote healing. And it is non-adherent. It will not adhere to the wound bed. It does require secondary dressing. You have to use it with extreme caution with exposed deep tissue because, again, an alginate, if it's a deep tissue, it will cause it to dry because it's going to soak every bit of fluid out of it. So you don't want to cause desiccation with those tendons or bone or fascia or anything that's an exposed deep tissue. You should change it daily if the wound is infected, because again, you don't want to hold that infection next to that wound bed. There's some common examples of the different types of alginates that there are. In the available forms of it, it comes in sheets, it comes in ropes. Ropes are used if there is a depth to the wound, so you can kind of stuff the alginate down into the wound itself. And then we also talked about the applicators, on the end of the Q-tip, so that you can see depth, or you can measure depth. Composite dressings, we talked about a little bit. Most have 3 layers, can be a primary or a secondary dressing. The inner contact layer is not adherent, and it prevents trauma to the wound bed, so it will not adhere to the wound bed. The middle layer wicks moisture. It generally a hydrogel, a semi-permeable foam, a colloid, or an alginate, and the outer layer is a barrier, and it usually is a semi-permeable film that's on the outside of it. So some examples of antimicrobial dressings that I've already talked about are silver or iodine dressings. It is a broad spectrum antimicrobial. It does decrease the wound bioburden. We talked about bioburden already, which is the amount of colonization of bacteria that's on the wound bed. But as I kind of said previously, there's no sound research to support the use of these antimicrobial wound dressings. You're still going to see them used a lot, but it truly is not evidence-based for long-term use. There is some research that talks about very short-term use, but overall, in the Cochrane review, it was not proven to be beneficial. All right, what are the precautions and contraindications? With silver, the main thing is that you need to make sure that your patient is not hypersensitive to any kind of metals. I always ask patients, are you sensitive to metals? And they may not know. So then I say, well, have you ever worn a ring or jewelry or anything that turns your finger blue or black, or you saw a discoloration around the skin? If they say yes, you should not use a silver on them because they do have a hypersensitivity to metals. So with silver, you will see a blue-black wound bed discoloration because that's the silver in the wound bed. Again, you can use it short-term to assist with infection control. you need to monitor for sensitivity, hypersensitivity, or the acute drug reaction. Don't ever moisten it with saline. A lot of times, when silver first came out, nurses were doing this. They would, because the wound bed itself was not moist enough, they would moisten the dressing, and that deactivates the silver. So you then have no antimicrobial agent on it because you've just deactivated the silver. You cannot use it with an electrical stimulation. You have to take it off before they go to an MRI. You should never use it on a neonate, and long-term use, it can be cytotoxic for immature epithelial cells and for the keratinocyte migration. Iodine, you have to be very careful if anyone's sensitive to iodine, if they have thyroid disease, or if it's a large cavity wound. You do not want to put these kind of dressings inside a large cavity wound. Common uses for antimicrobial are partial or full thickness chronic wound, donor sites, burns, venous insufficiency ulcers, neuropathic foot ulcers, pressure ulcers that are heavily colonized. So again, generally in the perianal area, you might get a heavily colonized pressure ulcer just because of where it is. So you can use an antimicrobial dressing for a period of time, or any kind of traumatic wound. Depending on whatever caused the trauma, you want to make sure that you're using an antimicrobial to get rid of those microbes. The benefits: it is broad spectrum antimicrobial. It is available in a wide variety of dressings. You have both adhesive and non-adhesive forms. It can be a primary or secondary dressing, and a benefit is for a heavily colonized pressure ulcer, as I just talked about. If it's heavily colonized, you can use an antimicrobial dressing for a small period of time, and you can start to see healing again because you've decreased the colonization of that bacteria or that microbe. Limitations: there's not a lot of research on it, and what is on it is not, at this time, does not support its use because it is very expensive. But there is a lot of it being used out there. Here's some common examples that you'll see. Aquacel AG, Acticoat, Actisorb are the ones I've seen the most. Silvasorb, seen quite a bit as well. Again, here's a picture of what it looks like. Let's talk a little bit about charcoal dressings. Again, this key function for charcoal dressing, there's nothing else other than control the odor. If your patient has a wound that has a high odor to it, it's going to improve the quality of their life, because socially that's not something that a patient's really going to put up with. If there's an odor to the wound, they'll tend to keep themselves at home or keep themselves away from people. And so anything, if you need something to control odor, a charcoal dressing, that is the only purpose of a charcoal dressing, is simply to absorb odor. Honey impregnated dressing, and it truly is honey. It's a Manuka honey. It controls the bioburden. There is some good research on this, and it will control bioburden, and it will also control a wound odor. So there are a lot of honey impregnated dressings that are out there right now being used quite a bit. It is antimicrobial. It stimulates angioblasts, fibroblasts, monocytes. It reduces inflammation and edema. There's an osmotic action that actually controls drainage because of the action that it has with the actual cells on the wound bed. And it may also stimulate growth factors because of and this all has to do with the honey itself. It says here, as you see purported, there is some research on it. It's fairly new. The research that's out there so far is pretty good for honey impregnated dressings. Collagen dressings. These are sheets, ropes, and padded dressings. They also comes in a gel, paste, powder, or particles. So you want to use a collagen dressing if you've got a non-healing 3 or 4 pressure ulcer. You can use it on a partial or full thickness wound. But if your patient is sensitive to collagen, obviously you would not use a collagen dressing. Again, these have very little research in them, but for a non-healing wound, these sometimes can stimulate the wound to begin to heal again. It stimulates the macrophages, the angioblasts, keratinocytes, and the platelets, protects the growth factors, provides a scaffolding for the cell proliferation and migration. It maintains a moist wound environment and it may encourage the balance between the MMPs and the TIMPs. I'm taking you guys back to our very first chapter. So again, it does have some, there has been some documentation of collagen dressings helping in some situations, just like the honey dressings. They're fairly new. They haven't been used for a long time, but they're having some really good success with them. Here's some common examples of collagen dressings. Again, very, very, very expensive, okay? And you need to be very careful if they're using a collagen dressing, because you have to handle them in a very certain way. Some of the foam, not foam, some of the gels, the things that are in tubes, have to be refrigerated and they cannot be left out. So there's some different ways of handling with these different types of dressings. Skin sealants and moisture barriers, I've talked about those. They just protect the skin from either maceration or adhesives. They have both wipes and sprays, and you use it on intact skin. You never use a skin sealant on a broken skin, so you never use it on a wound bed. It makes the skin kind of tacky, so that when you put the dressing down, it adheres better to that skin, but it also protects that skin. Moisture barriers such as ointments or creams prevents perineal rashes and skin breakdown. You can also apply a moisture barrier to macerated skin, because what it's going to do is prevent those cells that are already macerated from absorbing even more moisture. Because it's a moisture barrier, it's going to allow that macerated skin to dry out just a little bit. Moisturizers are a key component of basic skincare. They help restore the barrier function of the epidermis and maintain or restore skin hydration. You always, if you talk to a patient about moisturizers and you see when you're doing your examination of the skin that there is dry skin, then you do want to talk to them about moisturizers, but you also want to talk to them about always reading the label, and you do not want to use a moisturizer with perfume or alcohol. There's a lot of skin moisturizers out there. Always tell the patient, turn around and read the label, and if you see any kind of alcohol or perfume in it, then it's not the moisturizer you want to use for skincare. Apply it to only intact skin, never to the wound bed. Vaseline or petroleum may penetrate the best, and generally ointments are more occlusive, so they keep more out than a cream or a lotion. Tissue adhesives are things that are used generally by MDs. Rarely, I've seen a few PTs and skin clinic or wound clinics that use tissue adhesives, but 9 times out of 10 it's an MD. They are skin glues that they use for primary wound closure without staplers or sutures. I've seen orthopedic surgeons use them exclusively for closing a total knee or a total hip replacement. So they're used on acute linear wounds without tissue loss. Again, primary closure, it's a suture. It's going to go together with there's no difference in the two surfaces of the wound. And you must protect this wound from tension early on. So I have seen during acute rehab If you are too harsh on the incision site at the knee or the hip, if it's a total hip replacement, if it's a patient with a total hip replacement or a patient with a total knee replacement, and you're too rough with the wound, I have seen these bust open, the incision bust open. So you do have to be very careful if there's a skin glue about how much tension you're putting on that incision site or in early rehab, in acute rehab. Oops, did I skip something? So growth factors, again, extremely costly. The Regranax, I treated a patient who had a diabetic foot ulcer, ended up losing, became a trans-Symes amputation, and then became a below knee amputee. Used Regranax for a long time. As I said earlier, this is another one you have to be very, very careful. Very expensive. Has to be refrigerated. And this gentleman would have 3, 4, 5 tubes laying out on his bedside table. So they're not. Once they are not refrigerated, there's absolutely no growth factor left in them. So they become, and these tubes were $200 to $300 a piece. So it's incredibly important when working with a growth factor that you know how it's used. Another type of growth factor is Oasis. As you see down there, it's a porcine small intestine submucosa. Again, these are very expensive dressings, or sorry, they're not dressings, they're growth factors. They're topical that you put over a wound to stimulate growth. And they're not seen a whole lot. So here's the placement of Oasis on a patient with a chronic ulcer. So you see in A, they're moisturized. The Oasis is being hydrated because remember, this is the one that's the pig small intestine lining, submucosa. So it's been hydrated in A. They're preparing the wound. So what the surgeon is doing is scoring it, the top of the wound. Because then once, as you see in C, they put the Oasis on top of it, then it should adhere better to the wound bed. Here's the different types of growth factors that are being worked with now. You're probably not going to see something this specific. There's biosynthetic dressings and skin substitutes. They are coming from natural tissues, retain a barrier properties, encourage autolytic debridement, and create a granular wound bed. There's skin grafts. You have to be very careful about skin grafts and treat them with care because they are very expensive. There's allografts, xenografts, and autografts. Allografts is coming from another type of donor. A xenograph is coming from a human donor, and an autograft meaning it's coming from yourself. So it's your own tissue. These are very costly, limited supply. They have a very short shelf life, and some people have religious or cultural concerns related to skin grafts. But when a surgeon puts a skin graft on, you have to be very careful, keep it moist. You really want to save these as much as possible. And it makes the surgeon very angry if their skin graft dries out. So skin substitutes, the benefit to those is you don't see an immune response to them. And they can cover a wound. So, for example, someone who has, and it says this in the last bullet, if someone has a large amount of burn area, remember we talked about the biggest problem with that is dehydration. Well, if you can get a skin substitute over them, you can cover those burn areas and decrease the dehydration that's occurring with that patient. So that's the benefit of skin substitutes. Here's some of the different names of skin substitutes that are used. And let's talk a little, okay, so now we're going to talk a little bit about clinical decision making. And this is what I was talking to you guys about earlier. And I know we're getting to a shorter period of time, so I'll go through this quickly, but I want you to go back through it. Because basically, when you're making a decision about dressings, you want to know, is it draining or is it not draining? So if it's draining, what are you going to do? You're going to absorb the moisture and you're going to protect the peri-wound area. If it's not draining, you're going to provide moisture, okay? It's that simple. So you have a granular wound that's got a nice wound bed, or you have a necrotic wound. So what are you going to do? If it's granular, you're going to protect the wound bed from trauma. If it's necrotic, you're going to debride it. Here's a wound dressing decision guide. So there's both granular and non-draining. It's going to heal as expected. You're going to protect that granulation tissue, and you're going to maintain that moist environment. Okay, so there's some dressing options on this. If it's granular and draining, again, you're going to watch it, make sure that that drainage is not infection. You're going to protect the granulation tissue, absorb the exudate, protect the surrounding tissue, and again, it gives you some dressing options. Necrotic and draining, well, what do you want to do? You want to get rid of the necrotic tissue. You're going to keep a moist environment because it's not draining, so you want to keep a moist environment, and you want to protect the surrounding tissue. There's debridement options. There's also dressing options on this table. Necrotic and draining, again, want to observe them for infection because it is draining. You want to absorb that drainage or that exudate. You want to remove whatever necrotic tissue there is there, the eschar, protect the surrounding tissue. So again, this lists your debridement options and your dressing options. Other considerations, so if there is a wound infection, and we've been all through all this again, but I'll repeat it, you should avoid occlusive dressings if they're wound infections. You should bandage them daily. And here's some good dressing options if there is wound infection. So again, when you look at the wound, if it's small, you might want to use just a moisture retentive dressing. If it's large, you want to use gauze dressings. If it's deep, you want to fill that abscess formation. If it's tunneling, you want to use gauze dressings and frequent dressing changes because you really want to encourage the healing of that tunnel. You want to encourage the filling of that tunnel. And if the skin is fragile, you want to avoid adhesives or adherent dressings because you could tear that skin off. The frequency of dressing changes, if it's uninfected, you want to use a moisture retentive dressing and you want to do it less frequently. If you're using gauze, it's a frequent dressing change. Adhesive and moisture retentive dressings can be used for 3 or more days. Other considerations is what you have available. There's some health systems that don't allow, for example, silver dressings because it's too expensive. So you have to look at what's available for you to use. You have to look at the cost and you have to look at where the wound is located. Okay. So when you're looking at wound management, the main things you want to look at is there a granular wound bed? Is it moist? You want to keep it warm. You want to manage infection, and you want to eliminate dead space. If you guys can remember these 5 things, this truly is the key to wound healing right here. If you see a wound that doesn't have these components, then you're going to try to get to these components. This is what you want to create within the wound environment. You want to keep your peri-wound and your skin intact. Manage tissue loads, meaning if there's a bacteria or bioburden, you want to manage that. You want to control any factors contributing to healing or non-healing, edema, smoking, poor nutrition, and you want to enhance overall the patient's ability to heal. So here's some videos. I will make sure that these do get attached to Moodle for you. Dressing change irrigation. This talks a little bit about using an adherent occlusive dressing. You guys can go through this. The main thing I want to say is you should always initial and date the wound dressing so that the next person that comes along will know when it was done. This is non-adherent dressings and how to use a non-adherent dressing, the procedure for it. we will practice this. This is procedure for wounds with a dead space. Okay, I've talked a little bit about this, but read through this. I'm not going to spend a lot of time on it. Here's an example of how to fill a dead space. You don't want to pressure. The most important thing here is that you want to fill it, but you don't want to pack it so tight that there can be no granulation formation. Okay, so you want to fill it, but not pack it. Again, wounds with dead space, you want to leave a wick, and you want to put materials in to fill the wound, but not pack it tight. Here's how you would dress a finger. There's some tricks of the trade for hands. You use a figure 8. You don't want to use a lot of bulk on a hand because they need to use them. Legs and arms, you want to look for body hair or that kind of thing because it will affect how adherent they are, and it hurts the patient. Here's the Montgomery strap that I talked about. So you use this for large wounds, and basically these two sides, and I'll try to remember to bring in a Montgomery strap for you guys to see, but the two sides are adhesive, a large adhesive, and then you have a rope that you tie up the center. Okay, so it basically just kind of brings the two edges together. And there's an example of a wound that you would use a Montgomery strap on. You see how large this wound is? So you kind of want to bring it together. Once you pack it, you want to bring it together by using Montgomery straps. I've seen it used in this type of wound. Predominantly, I've seen it used in large, gaping abdominal wounds. All right, this is a dressing change with a Montgomery strap. Again, I'll try to get that video loaded for you guys so you can see. This is ankle and foot. You want to again use figure 8. You want to bandage it like hand wounds so that you don't want to use a lot of bulkiness because they do have their footwear that they have to consider. It says when it says consider temporary footwear, we always carried in our wound clinic. We always had the cast shoes, the cast boots, you know, the Velcro ones, because if you're going to wrap their foot, very rarely will the shoe go on it. Most people don't have shoes that are big enough to accommodate a dressing. And also you want to consider an assistive device because you've changed their footing.